Welcome to this episode of Substantial Matters, Life and Science of Parkinson's. I'm your host, Dan Keller. At the Parkinson's Foundation, we want all people with Parkinson's and their families to get the care and support they need. Better care starts with better research and leads to better lives. Sleep problems are common in the general population, and the effects of poor sleep extend far beyond just feeling tired. For people with Parkinson's disease, sleep disturbances are even more widespread and affect greater than 75% of individuals. Today, we'll focus on one condition in particular, REM Sleep Behavior Disorder, or RBD. Dr. Aleksandar Videnovic, chief of the Division of Sleep Neurology at Massachusetts General Brigham, explains why sleep problems are often underreported by patients and underdiagnosed by health professionals. RBD can be disturbing to the person with it and their bed partner, and can even be physically dangerous. We're joined also by Caron and John Poma, members of the North American Prodromal Synucleinopathy, or NAPS Consortium, who share their personal experience living with RBD. I started off by asking Dr. Videnovic to explain what REM sleep behavior disorder is and what causes it.
It belongs to the group of sleep disorders that are known as parasomnias. And what does this parasomnia term mean? It really reflects, and if you translate it, it means unusual behaviors which happen during sleep. And this REM sleep behavior disorder, as its name says, occurs during specific stage of sleep, which is called the REM sleep. During this part of sleep, REM sleep, we usually experience dreaming. During this part of sleep, REM sleep, our body is also paralyzed, so we cannot move, except our muscles that support breathing, they are still active. Somehow in this condition, REM sleep behavior disorder, that paralysis while we are in REM sleep disappears, is gone. So meaning we can move as we go through that REM sleep. And that is one cardinal feature of this condition, REM sleep behavior disorder. But then there is this segment that is relevant to dreams. In RBD, patients usually experience very action-packed, vivid dreams, which are in approximately 90% dreams that are filled with a negative emotion. Patients usually experience either fear or anger. They find themselves in very unpleasant situations. Frequently, they need to defend themselves. And then you tie that back with the loss of muscle paralysis during REM sleep. That means that those individuals can now act out their dreams. For example, if somebody is threatening them, they will try to defend themselves, and they can shout or scream or swing their arms or even throw themselves out of the bed. And this is in a nutshell description of what REM sleep behavior disorder is. Its cardinal symptom, its cardinal manifestations is dream enactment. And dream enactment occurs on the basis of loss of normally present muscle paralysis that normally accompanies that REM sleep. Usually, there is really no known cause of REM sleep behavior disorder in majority of cases.
How common is RBD and how does it come into play in Parkinson's disease?
Well, the newer studies have shown that this condition is much more common than originally estimated. We believe now that somewhere between 1 to 2% of individuals may be affected by this condition, especially those that are older than 50 years of age. And today we really understand, due to extensive research conducted over the past few decades, that in a large number of cases really presents a prodrome of an evolving neurological disease that can either evolve into Parkinson's disease or a Lewy body disease, or in a small percentages of patients into something that's known as a multiple systems atrophy. So RBD in a really large number of patients represents a prodrome, preclinical stage of this group of disorders that are known as synucleinopathies.
What's the impact of RBD in itself, both physically and mentally?
Obviously, if one starts yelling and screaming and shouting, moving, thrashing during sleep, that fragments the sleep for that individual that is going through it. Yeah. Our patients with REM behavior disorder act out their dreams. They are at risk of injuries. They can fall out of bed in the middle of the dream enactment, or they can hit their head on their nightstand, etc. But they also pose a risk to their loved one, to their spouses, their bed partners, and therefore safety is a really significant concern for patients with REM behavior disorders and their loved ones. And obviously, now that I mentioned this link between REM behavior disorder and neurodegenerative diseases, obviously there is an impact of having this disease and brain health and risk for that brain health in years and decades to come after the disease is diagnosed.
If people experience some of the symptoms you've described, when should they consider seeing a healthcare professional?
That is a really very important question. And why do I say that? Because this problem is really underreported by patients and underappreciated by health providers. Just let's put ourselves in a situation if we have one bad dream, or if we yelled or screamed, or maybe swung the arm and maybe hit our bed partner. Frequently we don't think much about it, right? There is so much going around us that we don't think about one bad dream as a big issue, especially nowadays. And this frequently causes delayed in diagnosis. And frequently these behaviors are repetitive. They will not happen only once or twice. They will come back. And something like this starts to happen, I would recommend that individuals who experience it reach out to their primary care doctors, to their neurologist. And a lot of patients in our Parkinson's community will experience REM sleep behavior disorder. Thinking about RBD, in addition to all of other things that can go wrong with the sleep in Parkinson's disease, is very important for our PD community. It is also important to mention that not everything that looks and sounds like RBD is RBD. And we just really don't want to cause a lot of alarm in the general public, or even with individuals who have Parkinson's disease, because some of them may not experience symptoms of REM behavior disorder. As equally as important is to know and pay attention to the symptoms, it is important to think through what other causes may be resulting in this type of behaviors.
What treatment options and resources are available for people experiencing RBD?
When we talk about the treatment of REM behavior disorder, there are several elements that are really very important. We start with the education, educating patients, educating bed partners. Then we address the safety elements of having this condition. It is really important to assure safe sleeping environment, and this means that there are some glass lamps or other sharp objects on a nightstand or in the vicinity of the bedroom. This needs to be removed. Sharp edges of the nightstands, for example, or hard surfaces like headboards, etc., should be padded, protected by extra pillows, perhaps. Sleeping in a bigger bed, it's much better than sleeping in a tinier bed, because the risk for injuries to self or to bed partner are going to be less if there is a larger bed, and risk for injuries is also going to be substantially smaller if patients are sleeping with the beds that have a lower platform. So these are some of the general sleep safety principles that we need to educate our patients about, and that are applicable to any sleeping environment, obviously not only to their bedroom, right? When they travel, when they visit kids, relatives, these elements need to be accounted for. We usually prescribe two groups of medications for managing REM sleep behavior disorder. One is melatonin, is considered a supplement, can be purchased over the counter. And another class of drugs is known benzodiazepines. These are two groups of medications that have been shown to effectively can reduce the frequency and intensity of these dream enactment behaviors. Sometimes we will combine these two medications, these two classes of drugs, in cases of more resistant symptoms of RBD. And I would leave it at this. There are several other medications that have been anecdotally reported to be beneficial, but I would focus either on benzodiazepine medication or melatonin or a combination of these two. And I would leave it at that. In terms of resources, I would really like to bring the significance of research that has expanded substantially over the past decade, especially on the topic of REM sleep behavior disorder. This is important now more than ever because we really do have an opportunity to develop and test potential therapies that may prevent development of Parkinson's disease and other synucleinopathies by intervening earlier. What do I mean earlier? Well, we have patients with REM sleep behavior disorder, many of them who may be on the road of developing Parkinson's or Lewy body disease. And now we can interfere years and sometimes a decade before signs of Parkinson's or dementia emerge. And therefore, it is really important to stay at it and continue to develop this research further. And in light of those efforts, a NAPS Consortium was formed, and NAPS Consortium stands for North American Prodromal Synucleinopathy RBD Consortium. It brings together clinicians and scientists from 9 academic medical centers in North America and brings together over 300 individuals with REM sleep behavior disorder. And we are really fortunate to have 2 of them join us today at this podcast. The objective of this NAPS Consortium is to understand progression of this condition into a neurodegenerative disease and to really enable us to understand who are those individuals who are having RBD symptoms, who are at risk of developing neurodegenerative disease, when that may happen. And ultimately, it positioned the NAPS Consortium to develop, as we have already done, a clinical trial-ready cohort of individuals in the very early stages of neurodegeneration who may benefit from these novel therapeutic advances. And I'm sure that Caron and John, who participate in NAPS Consortium already, will be able to reflect on their experiences and what this meant to them as patients and research participants.
While clinicians continue to learn more about RBD, many people living with Parkinson's say they had never heard of it until they've experienced it themselves. To help us better understand the real impact of RBD, as Dr. Videnovic said, we're joined by Caron, Gan, and John Poma, who are on the patient engagement board of the NAPS Consortium. Can each of you describe what you've experienced with RBD, and starting off especially with the early days and what you experienced? Caron, why don't you go first?
Sure. Thank you, Dan. My RBD journey started about 10 years ago with what my husband described as blood-curdling screams. He said they were so terrible and frightening, it sounded like someone was being murdered. And it scared the living daylights out of him because he didn't know where this was coming from and what prompted that. And I couldn't really remember the dream. So initially, these dreams were quite random and infrequent, thank goodness. So I chalked it off as stress or as something else. But over time, they recurred and they became more frequent, and the intensity remained the same, but they also became accompanied by physical movements. So throwing punches, thrashing my arms, moving my body, trying to punch, and eventually jumping out of bed and falling out of bed and hurting myself. Half my face was bruised and half my body. And so that prompted me to seek consultation and get a sleep study where I was formally diagnosed with REM Sleep Behavior Disorder. And I had never heard of this term before. And it was around the time of COVID that I received the diagnosis. So it would have been about 7 years after I started getting RBD symptoms. So it was quite late later on. And I was told that it was a precursor to Lewy body dementia, which really frightened me. And I eventually learned that I was not given full information to help me proceed. So I had to do my own research. I had to try and figure out stuff. And the one website that I found reliable, helpful information was the NAPS website. I felt I could count on them for good information. And that's where I reached out to them, actually, and became enrolled in their NAPS study. And at the time, I had not yet been diagnosed with Parkinson's. About 2, 3 years into the NAPS study, I was eventually diagnosed with Parkinson's. And because I had learned much more through the NAPS website and my consultations, I felt it better prepared me for the eventual diagnosis. It was upsetting to get, of course, but it nonetheless provided a bit of a soft landing for me at that time.
John, what were your experiences? Were they similar or different?
No, I would say the experiences are similar. Caron and I do share a lot of similarities and there are some differences because everybody does experience it a little bit differently. My first experience that we recall was not a blood-curdling scream for me. It was actually my wife flying off the bed, landing on the floor, hitting the nightstand and yelling at me, like, "What are you doing?" And I was having a fight or flight dream, and I attacked her in my dream and caused her to fall off the bed, and she's the one who ended up initially, with the bruise. In the beginning, we had no understanding that this could be related to a synucleinopathy or a neurodegenerative disease. We chalked it up the next morning to just being some random event where Beth said, "You must be under more stress at work than you realize." And I said, we went through a period we don't remember very well. Maribeth said, "I think you might have restless leg syndrome." And again, sort of an isolated event. And then another, really significant event happened again where I attacked her in my sleep. She said, "I really think you need to go talk with somebody. There's something wrong. You're doing odd things in your sleep." And I had been using CPAP since I was in my mid to late 30s. I just assumed, oh, my sleep apnea must be getting worse. And I went online, started trying to research and found my way to a neurologist at Virginia Commonwealth University and told her my story. And she immediately said, "I think you have something called REM sleep behavior disorder." I went for a sleep study. The sleep study confirmed it. Over time, my RBD has changed. I mean, initially, my only real memories of it were those events of that fight or flight type of dream. It now involves everything that Caron said, and the RBD can take many different forms. There are some days, some nights with the blood-curdling scream. I've yelled, people, guests could hear, "Get out of the house, call the police," and, at the top of my lungs. Or I've had full conversations in my sleep. I was an adjunct law professor, and I've had some conversations, that were just lengthy conversations. Again, there has been, the attacking of your bed partner, been the falling out of bed. And I thought sort of naively that if you develop Parkinson's later, that RBD would stop. I thought when they talked about it converting, that meant you would no longer have RBD. My RBD has continued, has also continued to progress. And it's also continued to be one of the more difficult non-motor symptoms to challenge and navigate.
What's it done to your Parkinson's symptoms as well as relationships or, say, overall quality of life?
So I would say that RBD has impacted quality of life probably more than other Parkinson's symptoms. So, first, in terms how's it impact your life? It definitely impacts your bed partner. It's not a condition that just affects the individual. It impacts the marriage unit or the partner unit. One of the creative things that we have done, again, I was diagnosed during COVID. I bought a plexiglass shield. I took insulation used around pipes and I put edging around the plexiglass shield. We have a adjustable king bed now. Last thing we do before we go to sleep is we put that shield between us. Although it protects her, it does cause some emotional separation. It's hard for it not to, cause some separation. I think, as Dr. Videnovic talked about, it causes fragmented sleep. And fragmented sleep has its impact the following day. I call it the spillover effect. It definitely impacts my Parkinson's motor symptoms. It impacts fatigue. It makes fatigue and exhaustion worse. I think it does impact other motor symptoms, impacts thinking. For me, I always say, there's a little bit more of a brain fog when I've had a particularly bad night. So I think the two are sometimes, they're interconnected. I think it can be hard to separate the Parkinson's from the RBD sometimes because they are intersecting and overlapping with each other. But some of my worst Parkinson's days are after a bad RBD night.
Caron.
Yeah, I would definitely agree with John. For me, the most troubling symptoms are the RBD symptoms, more so than the other Parkinson's symptoms like the motor issues. But it does have this overall effect on different aspects of my well-being. So sometimes, after a very intense dream, it could feel like I haven't slept all night. It could feel like I've been fighting off aliens or fighting off bad guys. And so those are the days I wake up extremely fatigued, and the rest of my day I have less energy. I'm not as sharp. I'm not able to be as active in different things. And so I have good days, I have bad days. And the nature of my dreams have changed as well, like John has talked about. Not all my dreams are violent or aggressive. A lot of them have become quite conversational over time. So my husband says I talk a lot in my sleep. So it wakes him up as well and it affects his fatigue level. But the interesting thing is I, like John, have been giving lectures in my sleep. And I've even been doing psychotherapy sessions with my clients in my sleep. And so if anybody wants a free psychotherapy session, they can line up in my sleep. And more recently, I've had these fits of laughter. And so Dr. Videnovic had talked about how 90% of the dreams tend to be negative or violent or aggressive. But more recently, I've had these fits of laughter dreams. I don't know where they come from. I don't remember what's so funny, but my husband has to stop me because I'm laughing so hard. He worries I'm going to have a heart attack and I'm hitting the bed because I'm laughing so hard. So it's really interesting how the dreams evolve over time, and I don't know what this means. I don't know if there are any gender differences around the content of dreams. So those are questions I'd be really curious about.
Anything on that, Dr. Videnovic? This is different from pseudobulbar affect?
Oh, well, thank you for mentioning this, Ken, because really there is 10 to 15% of patients who experience very pleasant dreams. They talk about beautiful flowers in the garden that they are walking through, or they are singing. You must have heard a good joke or something along those lines, and really do not understand this variability. And it is really important to point that variability is very significant, as Caron astutely pointed out. Both intensity and frequency of these dream enactment episodes fluctuate in time. And if one didn't have anything for 3 or 4 months, the following week may bring 4 or 5 of these events, sometimes even on a single night. So that is why it's important to really remain vigilant about these symptoms and pay attention to overall sleep, but certainly RBD symptoms as well.
Do either of you have strategies you've developed to deal with the RBD symptoms? Caron first, I guess.
Yes, I definitely have experimented with different things in my life and have found certain things can be aggravating of the dreams. So if I eat too late, if I have a big meal, if I consume alcohol, if I don't pace myself and I'm overstimulated during the day and overwhelmed if I'm dealing with extra stress. So those all seem to be aggravating factors. And things that help are number one, following a really strict sleep routine. Go to bed the same time every night, wake up the same time every day. And even with sleep fragmentation and being up sometimes because of the dreams, I still follow those same schedules. I stop eating and drinking fluids other than for medications after 6:30. So I have a period of about 12 hours fasting. That seems to have helped. Managing my stress seems to lessen the frequency of the dreams, and maintaining a really healthy lifestyle of nutrition, and most important for me has been exercise. So I've joined Rocksteady Boxing, and it's a non-contact boxing program for people with Parkinson's. I attend 3 times a week, and for me, it's almost like a dose of medication. When I miss the exercise routine, I feel more lethargic, I have less energy, it's harder for me to catch up. So, maintaining all those lifestyle things and choosing to live in a healthy lifestyle certainly does make a difference for me.
John, do any of those work for you? Do you have other strategies?
I mean, I would just add on a little bit. I agree completely with everything that Karen has said in terms of both daytime routines, nighttime routines. And one of the things that I try to do is even keeping a sleep diary. And sometimes I just do it myself on my phone, but keeping track of events and when they happen and what your day has been like, I try to find a pattern. I also do use a sleep app. I do find very helpful. There are many times that I don't know that I have had an event at night and my sleep app will report it. Ask your bed partner what they have observed, is particularly important. I think putting all of that together, why that's important, is so you can have a good communication conversation, communicate changes with your physician, work together with your physician, to sometimes adjust medication timing. And we've tried, different strategies of when we take medication in trying to address the events. But again, just reiterate what Karen has said, maintaining stress, maintaining mood. And one thing I always say when I talk about it is just also give yourself some grace, give yourself a sense of humor. It can be unsettling. I think one of the most important things you can do for yourself is try not for it to be upsetting and to laugh at it. Because, if you keep your sense of humor, it really does make a big difference for everyone. I think reduces some of the anxiety, and I think that's really is key for managing symptoms.
I think it really important to have an RBD buddy because it can be very isolating living with RBD. And I have found it very helpful comparing stories with John. And there's one other person in my boxing group that we compare stories with. And, we can laugh about some of them and make light of them. So, I would really recommend that people also develop or find an RBD buddy.
What advice would you give to people who are experiencing similar symptoms but really don't know what's going on, and what should they do?
So I think I work in healthcare and work in and around a lot of primary healthcare providers. Definitely talk with your primary healthcare provider. I had several visits before I mentioned anything to a physician because it was somewhat embarrassing. You don't walk into your doctor and say, "Hey, guess what? I attacked my wife in her sleep last night," without sort of getting. But I think it is very important if you are having any of these symptoms to talk with your healthcare provider. It may be REM sleep behavior or could be related to something else. But without having that conversation, you really don't know.
For more on REM sleep behavior disorder and information in general on sleep in Parkinson's disease, including tips on getting better sleep, search our website at parkinson.org for RBD, that's the letters RBD. As always, our PD information specialist can answer questions and provide information in English or Spanish about this topic or anything else having to do with Parkinson's. You can reach them at 1-800-4PD-INFO. If you'd like to leave feedback on this episode or to let us know what other topics you'd like us to cover, visit parkinson.org/feedback. Be sure to subscribe and rate us on Apple Podcasts or wherever you get your podcasts. At the Parkinson's Foundation, our mission is to help every person diagnosed with Parkinson's live the best possible life today. To that end, we'll be bringing you a new episode in this podcast series every month. Till then, for more information and resources, visit parkinson.org or call our toll-free helpline at 1-800-4PD-INFO. That's 1-800-473-4636. Thank you for listening.